Thank you for joining the first California Project Launch webinar, Mental Health Integration in Home Visiting, Technical Assistance and Lessons Learned. You will be muted as you join the call to avoid any background noise throughout the presentation. If you have any questions during the webinar and questions and answers section, please type them in the chat box. My name is Lilia Rodriguez, and I am a mental health consultant providing program support to Project Launch. I'm endorsed as an infant, child, and family mental health specialist, and have worked with over 12 years with mental health treatment services to children birth to 5, and provided mental health consultation to early Head Start and Head Start programs, and have worked as a home visitor for the last 26 years, providing support and services to infant and children with medical and developmental disabilities. And today we have with us Anna Gruber and Rita Lang, who will be presenting this webinar and promoting mental health wellness in our communities. So Anna Gruber, she is the maternal, paternal, child and adolescent health coordinator and unit administrator for the Alameda County Public Department of Health. Anna received her master's in social work from San Francisco State University in 1997 and a bachelor's degree in sociology from UC Berkeley in 1994. She is a bilingual, bicultural licensed clinical social worker who has served children and families for more than 20 years. As the maternal, paternal, child, and adolescent health administrator and Alameda County Healthy Start Initiative project director, she leads the integration, administration, program, and fiscal oversight of several family support programs for the pregnant woman and families with young children. Looking closely at social determinants of health and the strength of our families to promote health. In this position, she supports a multidisciplinary and diverse maternal, paternal, child, and adolescent health workforce to meet the needs of families and communities across the life course with specific attention to health equity. Prior to working for the Alameda County Public Health Department, Anna served as an administrator of home visiting and child development supports, as well as direct service provider and home visitor for organizations who promote the health and well-being of children and families. So welcome, Anna Gruber. And we have also with us Rita Lang. She is a licensed marriage and family therapist who has worked in the field of human services for over 25 years. She's a graduate of San Francisco State University and California State University, East Bay. Rita holds a Master's of Science degree in Educational Counseling Psychology. Her specialties include family systems therapy, dyadic parenting therapy, solutions-focused therapy, adolescence child play, and expressive arts therapy. Rita has worked for a number of medical school and social service agencies, providing comprehensive counseling services, and believes in people's innate ability to find their way to health and healing. Rita's experience additionally includes program supervision, program development, and consultation expertise working with a broad array of diverse communities. She has extensive experience as a local trainer, working in the past on First 5 Alameda County Touch Points individual level training team and providing training as a private practice therapist. Rita currently works for the Alameda County Public Health Department in maternal, paternal, child, and adolescent programs as the behavioral health clinic supervisor and program manager for the Blue Skies Mental Wellness team. Her consultation and program development work has been fundamental in implementing the mental health integration efforts for maternal, paternal, child, and adolescent health, behavioral health care, home visiting programs integration. Rita also facilitates the Ojima Collective Work and Responsibility Community Consultation Support Group for African American Service Providers in Alameda County. Rita has been happily married for over 3 years and has 3 children. So we're happy to welcome you, Rita and Anna.
Thank you. Thank you, Lilia. So today, Rita and I are presenting on mental health consultation and home visiting. So much of the work that we're sharing is from our experience in implementing this approach and this model in Alameda County. However, also in the experience that we've had over the last 3 years as a team of technical assistance providers. So Lilia, Rita, and I are part of a technical assistance team that also includes a few other staff. We have a mental health consultant part of our team, also Ayana Kainalo, and 2 others who are focused on family engagement in the public health system and in supporting home visiting. And of course, our whole team is led by our project director, Karen Finello. So just wanted to share a few of those words before we launch in. So we'll just wait for the PowerPoint to be pulled up. Great. Wonderful. So we'll start with the next slide. So in the beginning, when Project Launch first started and in our first experience in Alameda County with mental health consultation and home visiting, we had our first 5 Alameda County organization, which is a California organization for those that are not familiar, that is a tobacco tax initiative, and the funding automatically goes to early childhood initiatives. So pregnant women up to children who are 5 years old, and really supporting program services and policy work to improve the lives of pregnant women and family with young children. So in Alameda County, our first 5 did a lot of thinking around mental health integration in home visiting and was partnering very closely with the public health department. And back in 2008, they applied for a SAMHSA Project Launch grant and were awarded from 2009 to 2014 a Project Launch grant, where it really mirrors a lot of the work that we're doing now around technical assistance. First 5 was able to hire a mental health specialist who was stationed in the public health department in 3 specific home visiting programs. And that person was Rita Lang. And then they also provided parent cafes and strategies to support early childhood systems of care, and that was done also in the community. So a lot of community building, a lot of work to really seed and grow these ideas and initiatives around how to better engage families and how to bring mental wellness into our communities in a way that families were responsive to. Next slide. So what we learned in the early years, so in this time, we had an outside organization, First 5, trying to seed mental health integration in a public health system. And so we realized very early on that the mental health specialists had to really join and connect and build relationships with the home visiting staff. So there was so much relationship building done in those early years. It was really crucial. The mental health specialist, which was Rita, was participating in meetings, being visible, being placed. Her desk was in the program. So she wasn't primarily at a different location or a different site. She was really trying to integrate herself, her approach, her stance, and a lot of new concepts, I think, to staff around mental wellness and mental health. Observing programs' unique needs and style of the workers, we noticed that each program had its own approach, its own culture, and how we fit into each one, or how there was a fit in each one, was different. And I think I jumped over the non-expert stance, but I think that was really crucial to not kind of have the very clinical, kind of standoffish experience of what mental health was, so that it felt familiar and connecting and relatable, I think was very huge. And then I think in the time that it took to build relationships, we took time and held off on making recommendations, but really observed, connected, built relationships before really leaping in to say, you know, you should really be doing this, or, you know, you should be doing that.
Exactly. I think one of the most important things, I look back on this and it seems like a million years ago, but it's really nice to think about the non-expert stance, because coming into a series of home visiting programs in a public health system of care that was already well established, people already had their way of being together. And I think some of the hardest part was just accepting in a new person from an outside organization coming in as a consultant, and all that that means for people. Oftentimes when a consultant comes in, people feel like they're going to come in automatically making recommendations and automatically from a seat of judgment. So I think it was very important to just kind of build relationships, and that took a significant amount of time, but it was worth it, well worth it. Next slide, please. So what we learned in the early years was that it was very important, as I stated, to build relationships, to see if people really had their own concepts about what a mental health clinician would do and how they would bring services. And one of the best ways to bridge that was going out on home visits together. And that wasn't always the easiest thing either, because we were working with multidisciplinary approaches. Some might have been public health nurses, some might have been outreach workers, some might have been health educators, each holding their own unique way that they join with the clients in the field. And so one of the most important things that I learned, and we learned early as a team, was to really join with people so that they could feel comfortable with what we were bringing. And then to offer consultation back to staff once we went out and met the clients and were introduced, so that they would be able to hear what our perspective and what we were offering. And in this started to build trust with the various members of multidisciplinary team, because we try to keep our focus on a shared approach. It's not just coming from the clinician top down, but it's also listening to that nurse, listening to that outreach worker and what they see and how they see the client. So we try to fuse our stories together and work on whatever that initial presenting issue is, to diffuse that as we move forward with our treatment or our intervention efforts. Next slide, please. So one of the important things that I learned early on in the original Project Launch grant was that we would need to demystify mental health. Mental health held a lot of stigma. We were working with a lot of communities of color. People felt that mental health meant automatic treatment, diagnosis, and a stigma around how a person was feeling. So it was very important to come out and demystify that and explain to people that we are a prevention-oriented program, and that yes, we are clinicians, and yes, we can diagnose and offer treatment responses, but our original effort is to build a relationship, to observe that mom, that baby, that family, and see how we might be able to assist. And just in making that statement, just in presenting that approach, people, you could see them just kind of take a collective sigh of relief, because they often had a lot of stereotypes about what we would do and how we would present that. Next slide, please. So some of the major focuses as we began to integrate mental health into home visiting was really focusing on the well-being of that mother and the child in the context of a dyadic relationship. We really saw when we went out to home visits that that primary mother was first, and what was her story? What was she telling? And then we worked from a two-generation approach. We really wanted to hear her story, and then how she felt about her pregnancy and how she felt about her parenting. Really critically listening for the impact of stress and trauma in the family, which was really, really a huge and continues to be a huge barrier here in Alameda County. So a lot of our initial intake response was just listening to that trauma, listening to that stress, coming out, doing some meditation and some breath work and some relaxation with that mother. So each time she felt more comfortable, being aware of the vicarious trauma that the workers were also feeling. So in our consultation, we would be coming back to the office, talking to the workers about what they may have experienced in the family home or the community, and then really looking at providing consultation that was reflective, giving people a chance to really just talk about how they feel and how that might impact our ability to have brief interventions in the homes. Next slide, please.
In the mental health integration process, there were ongoing trainings for home visitors on various topics provided by the behavioral health professionals. So this is how we evolved over time. So after Rita was kind of the one-person mental health specialist in our project launch, after those 5 years, we then transitioned to Rita becoming an employee of the public health department and being the manager of a team of mental health specialists. So then we were able to really, and so here you're seeing in this part of the presentation, kind of how services evolved and how we were able to support home visitors. So the mental health providers started to participate very actively in case conferences, and at case conferences also offering ongoing trainings for our home visitors to really be able to raise their expertise and understanding of mental wellness and mental health issues that they were seeing so often with their clients. Current support was offered to the teams on various themes and topics that were connected to the case review process and case conferencing. So if we knew in advance what was happening in the case conferences, perhaps some time was carved out to be able to focus a little more on those details around what the presenting issues are with that family, so that everyone is learning together and we're able to really support the family in a deeper way. The monthly team case conferences were so crucial, and the most important takeaway of the last bullet, that third bullet, is around consistency. So the consistency of the mental health provider coming every month, even if there wasn't a topic to present upon or present with, but usually there was, because that consistency was helping to build relationships, to help support the team, and to be able to, grow people's knowledge. So that was.
And I must say that it's more than a notion to get that consistency, because teams in many of the public health programs, they met for administrative meetings, but bringing in reflective case review consultation was a new concept for them. So people were like, well, why do I need to do this? And what is this really about? But just showing up every time, we have a handout that we give that talks about the importance of case review and what case review is for, so that people have a place to come and talk about those difficult cases, so they have a place to share together and input together and strengthen one another on what they're seeing in the field, not only the presentation of the client. And so over time, it took quite a bit of time, but people began to see the value add of what a case review process was really about. The other thing I want to add about this is the topical themes in bullet number 2 that came out would come from us listening to the staff members about what their presenting issues were. So if we found that a lot of people across the board were talking about domestic violence, then my charge was to bring in a domestic violence in service. If we found people were talking about suicidal ideation, and we knew that there wasn't a lot of information about that in our system of care, then my objective was to try to bring in that. So it's one of the most important things is the consistency, and also really critically listening as a team of what issues are being presented by the workers. Next slide, please. So in this consultation, one of the biggest parts is the one-on-one consultation. We have a protocol in our program where once a case is open and the clinician does an intake, we try to come back within a 30-day period and meet with that referring party for one-on-one consultation. And we find it to be really helpful because it helps to continue to cement the relationship, but it also helps us understand what that home visitor is seeing in that weekly or a couple time a month visit, so that we can come in with the appropriate role. And we find that the workers find this really, really valuable to just have somebody to go to talk about what they're seeing in the family with the mom, with the baby, because they're alone. They often feel very isolated in the work. And so when the clinician meets with them, listens to their story, it further cements our plan of support. The other thing is we can come in and talk about screening tools that are necessary to really get a good assessment of that client. So we have a recommendation in our department that the Edinburgh is completed. We ensure or ask or request if that's been done. We follow up on any things that may have come out in that screening. We talk about the baby and we see with the child if there are any developmental concerns. We request that the ASQ is done, and it's done by our programs. And if it's not, and there's something that is glaringly coming up, we come back out as clinicians to offer a second screening so that we can identify and link these clients to the appropriate supports that are needed in the community. And lastly, for mother or dad, if we see any emerging mental health concerns that are really, really problematic early on, we want to make those linkages and those referrals for mental health, ongoing mental health treatment. They may be collateral, or it may be for medication management or other needs that may support that dyad. Next slide, please. So in this work, and when I talk about the consultation feedback that we really prize ourselves in giving, and we give a written consultation summary back to folks, because I really found it necessary for people to be able to see the clinician's role. It's very different what that nurse may be offering in her array of services, or that home visitor, but we really wanted people to see how the clinician saw the case and what our initial intervention strategies would be. We also wanted to be able to really, as I mentioned, support that worker in what they may be feeling, because in many of the cases when there's a lot of intensity in the home, if there's been violence in the community, there is a lot of trauma load that the worker is carrying. And so we take just a few minutes in that consultation, just a few, to kind of check in with that worker, talk about their own self-care strategies, and we support one another in what we're seeing in the community. And this goes back to us really leading that worker back to their own supervisor for their program to encourage them to engage in reflective supervision. This is our effort to really solidify what reflection is all about in the entire department. It's not just the reflective supervision that they may have with their supervisor, but it's also the reflection that they have with the clinician, and it's the reflection that we have in the case review process. So hopefully we're broadening just the scope of people being more aware and mindful of the work that they're doing. Another thing that we offer in that vein is quarterly transformational healing circles. This was a concept that I came up with after seeing the intensity of what people were holding here in Alameda County in certain high-risk communities. And this is something where we just pull together, and we may bring in speakers. We've brought in yoga teachers. We've brought in aerobics instructors. We may do an art therapy workshop. We do any number of things. We just did a last workshop on plants and healing, medicinal aspects of plants, and did a planting workshop here and just talked about the healing aspects of green. So all of these things, and we've seen an increase and an uptake in the public health department's participation in these type of events. And I really do believe there's a correlation between all of this and people getting good consultation, in them getting good case review practice, and in them having good reflective practice with their managers, and beginning to understand that we're in this together to transform ourselves to be strong and capable workers for our community in need. We also knew in the very beginning that these folks who offered the service needed to be licensed clinicians. They needed to be people who could come and hit the ground running with a specialty training. And in our hiring efforts, we look for early childhood mental health specialists who are licensed, who have that additional training, not only as therapists, but as child developmentalist specialists, so that they could work with the family and the mother if they present with any depression symptoms. Next slide, please.
Must-haves. So one of the things, these are the points that we thought were really critical in having a successful mental health consultation team and mental health brief treatment team that could provide clinical services and supports to our home visiting programs. We were utilizing and hiring very skilled and experienced mental health providers and professionals that were, our team, we were lucky enough that, we were intentional about making sure that they reflected the community that we were serving, and that there are always many discussions around the cultural issues, the racial dynamics, the racial issues that we see in our community and in the families that we're serving. And so to make sure that our mental health professionals also had that awareness and that sensitivity was hugely important. The mental health staff were very adaptable. So really bending to the needs of each of the programs, with each person who comes to provide, who is seeking consultation, and every family has, as you know, unique needs, and we wanted to make sure that we were always where they were at, and who we see as our client, not just the family, but the workers themselves. Learning to work in multidisciplinary teams that included public health nurses, outreach workers, health educators, and the mental wellness team also grew to include a substance abuse counselor. And I think that was very important and very critical to the work that we were seeing as new issues were emerging in the communities that we were serving. There was so much team building and understanding of the other and working with other disciplinary perspectives. How we work with nurses so different from how we work with social workers or outreach workers, and so how we could be adaptable and really be able to have the conversations of where people felt that how far their work and their interventions could be, and then where the mental health team could take over. Keeping wellness at the forefront of our work, which is not just for the mental health staff and the home visiting programs really, but I think as a unit is something that we were really striving for. But I think that it really was our mental wellness team and our home visiting staff that brought up these issues to the forefront more than any others. The issues of vicarious trauma and secondary trauma are so present, and these dynamics are with us so often, and our staff are mostly people of color, women of color, so we have our own issues that we bring to the forefront. And one of the things that we wanted to do as a division was really take on and become more reflective. I think the public health department does so well of having the stance of how to improve wellness in the communities and how to look at prevention. But we also sometimes can miss the reflective clinical piece. And so we hired and had a contract with our local Children's Hospital at Oakland, who had done a lot of work around reflective supervision. And we implemented a consultation group where all the managers within our family health services division participated in a training support group, if you will, around how to implement reflective supervision in programs and in administrative work, and how to have difficult conversations and how to support home visitors and other public healthers in the work that they're doing, so that it felt more collaborative, it felt more holistic, more consultative, more joining and collaborative in the work that we're doing. And then, of course, you know, the must-have is where do we find joy in the work? What is it about the work that we're doing is really satisfying and supportive, and what keeps us coming back to work every day, and how to really uplift that and allow us to continue to do the work that we want to do in a quality way.
And I think I want to add on that point, Anna, not just seeking the joy in the work, but recognizing that when we need to take a pause, that we can do so. And I think the mental wellness team, because we spend so much time at keeping wellness at the forefront of our team, at, you know, checking in at our monthly team meeting, and I checking in with clinicians in our reflective supervision about what are our real boundaries around the work, and how, if we don't know that, how can we call ourselves a wellness team and offer this to others in our community. So I think that becomes kind of infectious. You know, the more that we talk about that we do very difficult and challenging work, but we need to be aware of the work that we do so that we can try to do our absolute very best when we are healthy, when we're taking care of ourselves. Next slide, please. So more key factors for success that we realized was the designing of a referral and triage process where clients could be identified for the best match of clinician. And that's exactly what I'm talking about, that in my reflection with my team, hearing where they are in their lives, because their lives matter. We all have lives that we bring into the door. What does that feel like weekly to weekly? Certain cases may trigger workers because they have personal things that worker may be able to take 1 month, but at another month that may be a little bit too much for that worker. So we're trying to remain mindful of that. We can't do it every time, but when we can make a switch to another therapist that may be able to hold certain cases for a period of time, we try to do that and try to come up with kind of a wellness approach to looking at how we hold it. And then most importantly, trying to hold non-stigmatized language in working with families, because as I mentioned earlier, many of the families had so many negative associations with the word mental health. So much so, I'll tell you a little story. When I started, I was like, what should we call ourselves? Because I would go out in the field, and if I said mental health therapist, people were like, wait a minute, who is this that the nurse is bringing with me? If I said a mother's friend, and in the beginning I did say that, they would say, oh, well, let's see what that's about. So we evolved over time in how we might name ourselves, and always teaching the clinicians that it's very important to not use a lot of psychobabble or jargon that would be off-putting to communities that already had issues about dealing with mental health. And in that, and coming in with a really open stance and a non-clinical stance from the way that we presented the work, people were really, really open. They didn't feel like it was a stigmatizing approach. The other thing in working with some of the teams, we didn't want to come off as the expert, always knowing, always wise, always having the answer, because frankly, we didn't always have the answer. We had the answer from our prism or from our perspective, and so we wanted to create kind of a collaborative approach that was client-centered, solution-focused, and consultation approach. So right now, to this day, I'll see staff members walking up to a team member, you know, in the hallway, in their cubicles, in their office, just wanting to kind of check in about what they may be seeing in a family, and this is a really good thing. We also work to always solve the immediate needs of the mother. So sometimes the immediate needs were more psychosocial oriented, and we had to come in and be able to work on those needs, collaborate with that case manager and say, well, did you check on this, or is there a way we might be even able to assist with this to mitigate that crisis? And then once we found that happen, people were really open to the therapy, to the actual therapy where the therapist could come in and work with the mother on more emotional related work. And then lastly, we observed the whole family system, because we recognized that if the family system was out of whack, out of balance, in crisis, then so was that mother. And it made it very difficult for her to attend to herself, and most importantly, for her to attend to the baby. So oftentimes we may give just brief referrals out to that teenage son who got arrested, to that alcoholic partner who is dealing with issues, to that grandmother who may have cancer. We try to just make some broad-based referrals out in that way to help that mother feel a little bit more stabilized, and that allows us to move further deeper into connection with her and to be able to deeper engage in our therapeutic alliance. Next slide, please.
We work to find a blend of treatment resources for adults and children. So after doing some of the brief treatment work, how can we lead and connect to a pathway of the treatment end of the continuum so that families can be connected to longer term services and supports that they're open to, and that is a match for them. Work to establish treatment plans for clients that would allow for collaboration with existing home visiting programs. This was crucial. We really want to make sure that in our model, in Alameda specifically, but I think every program can look at what works best for them. We really wanted the clients to still be participating in the home visiting program, whether it was Nurse Family Partnership, Healthy Families America, one of our homegrown programs, such as, we have various programs, case management programs, and if the home visitor was still working on the case management issues, then the mental health staff can really focus on the mental health and the clinical concerns that the family was presenting with. And when they were collaborating together in the ideal world, this is how it worked best. The mental wellness team worked hard to build trust among cross-referral networks, so our own behavioral health systems and our own mental health supports and resources, so that when there was a concern or an issue that needed immediate attention, we had built those relationships where families can be connected in a smooth and easy way. The bi-monthly home visits to connect clients to mental health care, medical evaluations, and crisis intervention services was always primary for our mental wellness team. And of course, we shared about how important it was for us to hire a diverse staff of mental health professionals who really represented and believed in the work that we were doing with our client population.
And I might add with that point that when we started in looking for a diverse clinical staff, so that we would have a Latina therapist, we had another African American therapist who could work with our families. And as we began to build trust, and as people began to see what our work was really about, now I find they're much more open to working with cross-disciplinary and cross-cultural therapeutic alliances. I think in the beginning it was kind of like a trust issue, like, well, who can I really share my story to? Will they really understand me? Once they saw that the work was established, they're like, well, really, I like the work, so it doesn't matter who the person is. But it took some time to get to that place as we built trust. So I think that's an important piece to kind of look at as programs are designed. Next slide, please.
And I think connected to this, the slowing down, because, in particular, you were bringing up, Rita, the diversity of the mental wellness team. It took time for us to hire because we were very committed to making sure that we had the right match. And it took time for us really to be able to, as many people know, a civil service process in a public health system, you're relegated to processes that are very time consuming. And when you are committed to finding a certain type of person that you feel is the best match for your programs, that takes even more time. Yes. So whereas we could have hired someone within 3 or 4 months, for us it probably took a good 8, 9, 10 months. And it was the same when we wanted to hire Rita as the manager coming from a First 5 program into a public health system. And so it takes time to slow down, to make sure that you're focused, especially when everything around you is really the administrative component weighs heavy.
It's moving at its own hyperspace. But I think that in the slowing down, that is really a mental health integration into a public health system, because it's a different way of kind of looking at things, that we really want to be mindful about what we're trying to do. And I think that goes a long way in our success and being able to not rush it, but just really think through what our interventions will be, not only with families, but programmatically as well.
And I think, Rita, too, you hold often the stance in managers' meetings and in a lot of our work to remind ourselves, you know, what it really takes to slow down. We've even incorporated a moment of Zen in our managers' meetings so that we can be more thoughtful, I think, in the work.
Yes, and thank you, Anna. And I think we, as mental health team, we notice this. So when there are, when either the staff comes to us and says, well, can I think about this a little bit and get back to you? We're like, victory, right? Because typically there is a press because of the need. And we all recognize the critical need of our clients and our communities. So we're not saying that we don't take that for granted, but we do, in terms of our operations, want to think about thinking through things clearly before we act all the time, because I think that makes a difference on both sides. Next slide, please.
So some basics. We have, for one full-time licensed mental health consultant, they typically hold a caseload of 15 to 20. Services are provided in the home or in the community and in the office, depending on what the families need. And this is the same for our home visiting, even though we say home visiting. We did an evaluation with clients or with participants who declined home visiting services, who declined any type of family support service within our system. And we serve about 2,000 clients a year. And the people who declined services said, well, I don't know if I want you coming to my house, or I don't have a house for you to come to, or I live with other families. And so I thought that I couldn't, you know, this wouldn't work. So we've really shifted how we approach our services and supports. And so if families want to meet at the office or in any community setting, that's fine for us. The mental health provider typically sees a family twice per month or more if they have more intensive needs. And then they provide one consultation to staff at case opening and one written consultation, as Rita was saying, on the mental health issues and needs and recommendations 30 days after they start to see the family. Next slide, please.
So, Anna, go ahead and talk about the Title 19.
Title 19, yes. So we, from the very beginning, all our staff, except for those that are funded through a federal funding stream, all leverage some form of Title 19. So Rita, currently, for those that are in California and are familiar with the maternal, child, and adolescent health budgets, Rita is listed on our budget, and she leverages Title 19 through federal financial participation, which is a form of MAW. Our mental health staff currently that are under her are funded locally through Mental Health Services Act, and they also leverage Title 19 through behavioral health services. So everyone is leveraging. And at one point there was, in another program that we had, a mental health specialist that was doing a lot more clinical case management with, I think, the mental health as an overlay, but really her focus was very much clinical case management, and she was leveraging at one point targeted case management. So we try and make sure that through one form or another, through the funds that we're receiving, if they're considered certified public expenditure dollars, that we're able to have some form of leveraging to really be able to sustain the program.
And I wanted to say the second bullet, don't forget to have a child development focus, because here in maternal health, we really want that therapist clinician to be aware of what's going on with that child and bridging the two. It's one thing, you know, we had a lot of interview candidates who had strong clinical backgrounds in adult mental health services, but they had no background in working with children, young children, and families, and they didn't have a developmental focus at all. So that's a really important point, to bring in people who have that and who can focus on healthy parenting as a balance. And then again, balancing that prevention oriented approach versus just coming in doing straight treatment, because we're looking at preventing mental illness in the community or preventing mental health related disorders. Most of the families that we see, 90% are mild to moderate treatment options. So we're offering things for people who have perinatal mood disorders, mild symptoms of depression or anxiety. Occasionally we'll get people who have a much more severe presentation, and then in that case, we're doing a crisis referrals to get them into long-term treatment or into a place where they can be seen that's more supportive for them. And as Anna mentioned, sustainability is the key, and we're learning that and we're moving forward. We continue to do our Mental Health Services Act grant in partnership with behavioral health care, and that's working well. And that grant, that MASA grant, is about linking services as well. So it's finding resources and making sure that our clients are referred into additional longer-term treatment options for mental health. Ongoing workforce development is a key for our entire department, not just for the mental wellness team, but for all our workers, that we can raise people's ability to do a really good job and to learn about certain key issues that impact their ability to do the work. And I think we all give out, incentives. All of our home visiting programs give out incentives. But in Blue Sky's mental wellness team, we focus a lot on developmental toys, journals where moms can write out their feelings and where we can kind of tag in cognitive behavioral approaches with what they're writing out when we're giving, homework assignments to them to think about their parenting or to work through their depression or things like that.
And the only thing that I will add would be, as you develop your mental wellness teams or your hiring of mental health clinicians, to be able to have outcomes from the beginning, I think is very crucial. As we're growing and getting more referrals, I think what people want to see more than ever, as we know across all our work, are what are the data, what is the max that people do, what is the maximum people can do, and are families better off? And so we're right now refining results-based accountability measures for the mental wellness team. And next slide. I think we're at questions now. Great. So good timing. We have time now for questions. Let's see. If you have any questions, you want to type them into the chat box. So I think another option too is, as people think about questions or needs that they have, Rita and I are open and available. You can email us directly, especially if you can't, think of anything in the moment, or for those that are listen to this PowerPoint or listen to this webinar after the fact through a recording, through the Project Launch site, we'll be posting the PowerPoint presentation as well as this webinar and our email addresses should something come up after you see or after you listen and watch this webinar.
And that's all I see is, can we get a copy of the PowerPoint? And can you describe the Mental Health Services Act grant or share the Mental Health Services application so we can see it?
Yes. So the Mental Health Services Act grant is usually administered through the local behavioral health departments. And so what happened with us is, as we were wanting to grow this mental wellness team, we had a lot of support from leadership in our county. And we had built relationships, and there was a lot of support around home visiting and supporting pregnant women and families with young children and having an early childhood eye to the services and prevention activities. And so our healthcare services agency leadership connected us to behavioral health services and told us there are Mental Health Services Act dollars that are available, and we would like you to fund public health and have some cross-departmental work happen. And so we didn't have to do an application. It was really the leadership of agency that brought us together. I think what was helpful is, typically in maternal child health, there are mostly nurses that are the leaders and the managers, and I happen to be an LCSW, and so I think I was able to connect with behavioral health services. We spoke a similar language, and we were also very responsive in developing job descriptions of what a mental health specialist could be, what leveraging opportunities were. There was some tweaking and some massaging there, but what we hope to do is on the Project Launch website, we are working probably through this summer to be able to post not only this webinar, this recorded webinar, but job descriptions of our mental health specialists, job descriptions of the mental health manager, the clinical director, so that you can use those as templates and guides for you in your own work and trying to grow your mental health consultation work. And our email and contact information is already on the Project Launch website, but I can also share it with everyone right now so that people can have it. It's anna.gruver@acgov.org, Anna, ANNA, .gruver, GRUVER, @acgov.org. And for Rita?
Mine is Rita, RITA.Lang, LANG, @acgov.org.
Thank you. Thank you for adding that, Karen. So I think if there are no other questions.
Thank you for listening, and it's been a pleasure talking to you all, and feel free to reach out if you have any other questions in the long run.
Wonderful. Okay. Thank you, everyone.
Thank you.
And thank you, Lilia, for the support as well, and Karen.
Thank you, and thank you to Excel, who has been helping us with technology.
Thank you, Excel. Have a good day.